Hi, I'm Dr. Jeffrey Whitman of the Key Whitman Eye Center. And what we're going to show you today is our basic workup and how it's been enhanced by the Epic workstation. We have found that using the OPD system, the ability to do digital refraction, to be able to look at internal and external astigmatism, lets us thoroughly evaluate our patients from pre-op to operative data such as picking lens implants, to simply giving patient a refraction or knowing, is this some irregular cornea, irregular eye that we're going to want to do something different with surgically? I think that you will find that the Epic workstation is a reliable and large advancement in what we do in ophthalmology today. So at the beginning of the exam, we want to get a good feeling for what's going on with the patient now. We want to get chief complaint, past medical history, because these things are going to guide how the exam goes from this point. Since we find that cataracts are really a gradual process for most patients, it happens obviously as they get older, but we have younger patients with PSC cataracts, patients that have had retinal surgery before. Again, we need to find out all these things so we know what to look for in this exam. So we got to begin that conversation with the patient and begin that exam so the doctor has everything at their fingertips to make the right decisions. Now we get to my favorite part of the exam, and that is the OPD. This is really the star of this workstation because it's going to give us a starting point in terms of a digital refraction that we can actually put into the manifest refraction that this instrument allows us to do as well. So we get more accuracy. But not only that, we're collecting a lot of other information. Corneal topography, wavefront measurements. We're going to be able to look at mesopic and photopic pupil size. So when we're done with this exam, we know, is this cornea irregular? Is there something we should be suspicious about the tear film? Again, OPD, the hallmark of this system. Now let's talk a little bit about refraction. Using this prescription allows us to determine how much focusing power each eye needs to get as close to 20/20 as possible. We need to determine if the patient is okay and reading comfortably with their current correction, or do we simply need to go to new glasses, new contacts, or is surgical intervention necessary? Certainly when a patient has cataract problems, sometimes their complaint may merely be, you know, when I'm driving at night and car lights hit me, it blinds me. Or during the day when the sunlight hits me, I just can't see as well. When in normal lighting, their vision on manifest refraction tests just fine. That's the time for glare testing. And in the past, you know, a lot of us have used brightness acuity testers, and we know that if we hold them one way or the other, we have to remember to have them on the right illumination. We get very varied readings. But on the OPD system, we get precise computer-controlled readings every time. So we know the light source is the same. We know that what we have them looking at in terms of letters are the same. So we can really test for contrast and see if does this patient need cataract surgery? Do they have early PSC, early cortical changes that require surgical intervention to get the best vision possible? You know, one of the things we can pick up in an early OPD exam is looking at the placido disc image. When we look at that and we have the patient blink, we can often see that it's irregular every time they blink, and we know, hey, I think some dry eyes going on here. To confirm that, we can do a tear lab test to look at tear osmolarity. We certainly can do other tests because as refractive cataract or refractive surgeons, we want to get the best vision possible. We don't address dry eye problems prior to surgery or even contact lens wear. We're going to have a dissatisfied patient. One of the beautiful things of the OPD system is that we get a very nice topography, but like most refractive surgeons, I would like to get more than one source. So we'll usually get an orb scan or a different type of topography, maybe an ISIS, so we can compare it to the topography we get on the OPD, because we like to make sure these agree, particularly if we're considering a toric lens implant or another refractive lens such as crystal lens or a multifocal lens, where we want to be as exact as possible in calculations. Because of the complexities of insurance billing today, whether it be through private insurance or CMS Medicare, we need to do specific visual acuity questioning now to check for activity of daily living issues. It's not enough just to see that the patient can't see well and that they need cataract surgery. We have to do a thorough visual analysis of activity of daily livings to document that surgery is necessary. Now we've decided the patient needs cataract testing, but the important thing to remember here is that when you get this information, you do not want to touch the cornea yet. So we can see that we've gone through a whole exam, and all of it's done centered around the OPD system of the whole workstation. And we can see that this has really simplified things. We can do our manifest refraction based on digital refraction. We can do glare testing. We can check pupils. We check topography. We check wavefront, all sitting at the same station. We have placido disc image. We can actually look at a picture, a retroillumination picture of the cataract that we can show the patient. So we can demonstrate to the patient that here's the pathology that we need to work on. Again, I can't emphasize the importance of getting an OPD for your practice. It really is an all-in-one instrument that allows you to do so many functions in one position where you're not moving the patient around, so you can make a quick decision on, is this a patient a good candidate for a toric lens implant, an accommodating lens, a multifocal lens? Perhaps they have too much coma value and you're worrying about too much contrast for certain multifocal lenses. This unit shows us all those things at the same time. Well, again, without having to move the patient around, the doctor can come up, say, Ms. Jones, this is what your problem is, this is what we need to take care of, and here are our options. And we move right along, one of the most efficient instruments in my practice.